Hello, everybody. You're very welcome to this lunchtime webinar. And the title of our webinar today is the CervicalCheck Eligibility Framework and Special Screening Circumstances. My name is Dr. Sarah Fitzgibbon, and I'm the Primary Care Clinical Advisor with CervicalCheck. So today we're going to be looking at the eligibility criteria for participation in CervicalCheck screening. At the end of this presentation, you should know the screening intervals for the different age groups, and also to understand the circumstances where either additional screening is required or those situations where cervical screening is not recommended. It's also important to be aware of the appropriate time intervals for repeat testing and post-pregnancy and the reason for this. And we will then consider various clinical scenarios and try and recognize and manage situations which could fall outside of the eligibility framework. So a reminder, I know everybody knows this, but a reminder that screening is for healthy people. The intervals between screening tests are regular and they're determined by international best evidence. Screening itself runs parallel to our life course. So the screening intervals are more or less fixed and are unrelated to symptoms or other life events. A reminder of the screening pathway. So any screening program, its purpose is to identify the population eligible for screening. So in the case of cervical screening, that is anybody with a cervix. The screening program arranges invitations and information to be sent out to the eligible population, and letting them know about the risks, benefits, and limitations of screening and inviting people to participate. Screening obviously is a choice. A person chooses to attend for their screening test, and then if their screening test is positive, they will be referred onwards for further diagnostic tests, or if the screening test is negative, a person returns to normal recall. A person who's had a diagnostic test and it turns out that no abnormality is detected will also be returned to normal recall. So we mentioned about the life course. So we're just going to look at a little bit of a timeline here. So cervical screening in Ireland begins at the age of 25. And at that point, a person will attend to their GP practice or to their health clinic for their first cervical screening test. The next screening test after that is 3 years later. So if they've come at 25, that'll happen at 28. And again, 3 yearly up to the age of 30. So meaning that the next test after 28 will again occur 3 years later. Again, sticking very closely to the timelines, this person will be having their screening test at the age of 31. Between the age of 30 and 65, the screening intervals turn to 5 years. So if we look at that, you're going from 31 and next one due 36, 41, 46, and so on up to 65. Let's look what happens when we add in some other life events. So in this particular example, this woman becomes pregnant at the age of 26. And so we wonder, does she need an additional screening test? Should she have a screening test at that time? Her next screening test is due when she's 28. So this pregnancy has very little to do with her screening interval. She has her pregnancy, she proceeds, and then when she's 28, her screening test is due again. Same thing applies if she has another pregnancy, we'll say at the age of 30. Again, it is irrelevant to her screening pathway. Her screening test is due when she's 31. This pregnancy does not impact on that. What happens, we'll say, when she's 42 and she has some irregular bleeding? Should we do her screening test early? She's already had her screening test done here at the age of 41. And this is a very common question that arises. What happens if she has irregular bleeding? Is this the time to bring forward her screening test that she was due again at 46? And we know that, again, returning to the fact that screening is for healthy people, is for asymptomatic people. If she has irregular bleeding, then that needs to be managed through history, investigation, and a diagnostic pathway, not through screening. Her symptoms do not impact on her screening intervals. She had a normal screening test at 41. Her next screening test is due at 46. What about her menopause? This occurs for her at around about the age of 49. Should that impact on how frequent her screening is? It should not. Her next screening test would be due again at the age of 51. We do know that menopause can impact on people's attendance for screening, and oftentimes people might think that after the menopause that they don't need to continue to have cervical screening. And it's really important that we support women to attend in the postmenopausal period. We know that it can be a little bit more uncomfortable for people. And again, there are things that we can do in our general practices and in our clinics to support women to attend. So again, she should attend at 51 as she's due with a normal result. She attends again at 56, and then she attends again at 61. And at that point, again, everything being normal, her screening is complete. And just a reminder about why we've been able to change the screening intervals now that we have a HPV screening program. So high-risk HPV tests have a high negative predictive value. And this means that while in the past, our cytology screening was every 3 years up to the age of 45, now we know that with this high negative predictive value of the high-risk HPV test, that it is just in the years 25 to 30 that a woman would need her screening test done every 3 years. And then from the age of 30 to 65, it's sufficient for her to be screened every 5 years. In fact, we know that increasing intervals does not sacrifice protection. And so the efficacy of screening, even with the extended intervals, is as good, in fact, better than cytology screening. And there's the additional benefit of a reduced number of screening tests over a person's life. And a reminder again of how important it is when we're discussing with prospective patients or people who are coming to attend for screening to really go through with them the benefits and potential harms or limitations of screening. There are undoubted benefits in terms of reduction of the diagnosis of cervical cancer, including the reduction of cancers diagnosed at a later stage. But there are also potentials for overdiagnosis and overtreatment, as well as false positive and false negative results. Any interaction with healthcare can be anxiety provoking. So having a test done, waiting for a result, and then receiving the result, all of these can potentially cause negative physical and psychological impacts. So we're going to look now at the eligibility criteria for participation in CervicalCheck. And we've mentioned most of this already. So age between 25 and 65. There's a little asterisk there next to the 65. And that's because women who had already finished screening when we moved over to the HPV screening program in March 2020, they would have already received what's known as the goodbye letter from CervicalCheck. So they would have been told that their screening journey was complete. And yet now they hear that our program has been extended up to the age of 65. So there is a cohort of women who are not yet 65, but who have been told that their screening is complete. And we are looking at that cohort of women to assess their needs and to see if potentially offering them a HPV test, which they would not have had done under the previous program, might be something that they would be interested in participating in, because we have had feedback from women in this age category expressing disappointment that they are not being offered a HPV test despite being under the age of 65. Our eligible population is women and people with a cervix, and we mentioned our screening intervals: 3 years from 25 to 29, 5 years from 30 to 65. However, if a person's test comes back as HPV positive, they will be recommended to return for a 12-month repeat to have the HPV test done again. This is in the circumstances where their cytology is negative. People who've been discharged from colposcopy will be advised as to their screening intervals, and these are determined by the colposcopy algorithms. There are some specific populations that require increased screening, and really this is quite straightforward. We often get queries as to whether somebody would need an increased intervals or more frequent screening tests, and there are two major categories where this is recommended. So for people who are immunosuppressed as a result of being pre or post-transplant, or who are on renal dialysis, they are recommended to have increased screening. And the other category of people who are recommended to have additional screening would be those people who are living with HIV. So immunosuppression as a result of being pre or post-transplant, or on renal dialysis, or living with HIV, those are the circumstances that require increased screening. Immunosuppression for other reasons, including medications being prescribed for rheumatoid arthritis, for psoriasis, for any one of a number of other conditions, do not require increased screening. It is really important to remember some additional risk factors for cervical cancer that we don't always talk about. And the main one of these is smoking. We know that people who smoke and have HPV infection are much less likely to clear the HPV infection, and therefore more likely to have persistent HPV, which, as we know, is the main risk factor for developing squamous cell carcinoma of the cervix. We've mentioned about the categories of immunosuppression, which add additional risk. And then there is another small category of women who have been exposed to diethylstilbestrol when their mothers were pregnant with them. And they are at increased risk of cervical cancer, but it's clear cell adenocarcinoma, which is a very specific subset of cervical cancer and is not related to HPV. And so therefore they have no value in increased HPV screening. They do require additional surveillance, which is provided through specialist clinics. There are some groups of people who don't need cervical screening. And the most obvious of those, I suppose, is people who don't have a cervix. So that could be somebody who was born without a cervix, or in the case where a cervix has been surgically removed. So somebody who's had a total hysterectomy, so the cervix has been removed, and there was no evidence on histology of any CIN or abnormal cell changes. A person who's had pelvic radiotherapy is recommended not to have cervical screening carried out. And there could be a personal choice. Somebody might just simply choose not to participate in screening. People who've never been sexually active would be deemed to be at low risk because their risk of HPV infection is low. However, the caveat with that is that it's very important to discuss with the person what they mean by sexual activity. Any kind of sexual contact can result in the transfer of HPV from one person to another. So that's any kind of skin-to-skin genital contact that does not need to have been heterosexual penetrative sex. Many women in homosexual relationships and their clinicians are under the false apprehension that they do not require HPV screening. But in fact, any kind of, as I say, genital contact at all, including the sharing of sex toys, digital penetration, oral penetration, any of those types of sexual contact is an opportunity for HPV to be transmitted. So anybody with any kind of sexual history at all should be offered HPV screening. So this is our framework that you can see when you either click on the link or you can go to the CervicalCheck website. And this is just showing us exactly what we've been mentioning about the routine screening in the different age categories. This is our special circumstances. So again, as we've been speaking about, people who are post-colposcopy will be recommended as per the algorithm. We mentioned about women who've had a hysterectomy, who've had their cervix removed, and who've had no CIN, nothing evident on histology. They do not require further screening. For women who've had CIN or they've had abnormal cell changes in their cervix at the time of the hysterectomy, their follow-up should be undertaken by their treating clinician. And sometimes what happens is that a woman is not 100% sure either why the hysterectomy was carried out, or if, she might not be necessarily sure about the histology. And we also know that in primary care, it's quite common that we wouldn't have access to the histology data, or that the discharge letter from the hospital is either inaccessible or incomplete. If possible, it is great to try and actually get that information from the source, from the hospital where the procedure was carried out. If that's not possible, the recommendation is to have one further screening test, so a HPV test of the vault. And if that is negative, again, she can be discharged from the screening program. And again, further down the eligibility framework, we're looking at people living with HIV, those undergoing renal dialysis or waiting for transplant, and people who've had pelvic radiotherapy. And that can be for any type of cancer. So for cervical, bladder, rectal, or any other pelvic cancer. So radiotherapy in the general pelvic region precludes further cervical screening. Taking a test outside of the eligibility framework in a GP setting will result in no payment. So while it's very important from the woman's perspective that she is only offered the screening test when it is due, there are also implications from the point of view of payment to the practice. And that sort of brings us to this idea of non-program screening tests, or what might be termed private smears. And it's very important to remember that the promotion of private screening undermines population outcomes. Screening is a population-based intervention, not an individual-based recommendation. There are increased risks of over-screening when you provide screening tests at intervals that are more frequent than those recommended by the international research. They are a source of conflicting results for the woman and her doctor, which can cause uncertainty, anxiety, concern. Any data that is produced as part from a private screening test is not included in her CervicalCheck screening history. So this isn't available to the CervicalCheck labs when the woman comes to her next CervicalCheck test, and cannot at this current time be incorporated into her screening history. For women under the age of 25, for whom HPV is very common, and CIN, both CIN1 and to a certain extent CIN2 are both very common in this age group. What we know is that screening at this time, the risks definitely outweigh the benefits, because you are likely to have a false positive result, which could involve attendance at colposcopy, potentially a treatment that isn't required, such as a LETS procedure, which can then have further consequences down the line in terms of pregnancy, early miscarriage, premature labor, etc. And again, remembering that a negative screening test could falsely reassure a woman with symptoms. Sometimes when a woman comes and asks for a screening test that is not yet due, it is really important to stop and ask why. Why would I do a screening test if it is not due? Remembering that a screening test is not a diagnostic test. If the woman is asking for it, very often it's as a result that she's having symptoms. So it's important to stop and ask her, why do you want your screening test now? If she has concerns about the safety, or she's wondering about her risk, it's very well worthwhile speaking to her about HPV, about its impact on cervical cancer risk, about the other things that have impact on cervical cancer risk, and really talk with her about what are her concerns, and to try and help her to understand the efficacy of screening at the intervals as they are prescribed. So just some special considerations which often arise. So if a woman is pregnant and her screening test is due during her pregnancy, there's no need for routine screening at that time. If this routine screening is delayed until after her pregnancy, 3 months after her pregnancy, which we will discuss, then that's no problem at all. There's no difficulty there with that. If she'd already had an abnormal screening test before she knew she was pregnant, or had already been attending colposcopy, then she should follow up with colposcopy during the pregnancy, and they will talk to her about any concerns that she has. It is very important to wait 3 calendar months after delivery, or the end of a pregnancy. So whether the pregnancy ends in either delivery, miscarriage, ectopic pregnancy, or termination, it is important to wait 3 calendar months before taking a cervical screening test. That's because the hormonal changes during pregnancy can affect the cells of the cervix and make them more difficult to analyze once they get to the lab. with breastfeeding, the only consideration is, again, waiting for the 3 calendar months after delivery. So breastfeeding in itself does not delay or change the interval at which the screening is done, other than waiting the 3 calendar months after delivery. It's worth remembering, though, that the test might be a little bit more uncomfortable due to the vaginal dryness caused by hormone changes during pregnancy. Any repeat test, so for whatever reason, if a test must be repeated, again, it's very important to wait 3 calendar months after the last test, or the test won't be processed. So this could be if the first test was inadequate, or was lost in the post, or there was some issue with the test and it needed to be repeated. You must wait 3 calendar months. If a woman has 3 inadequate tests in a row, the lab will recommend a referral to colposcopy. So we might look now at some clinical scenarios that arise, and what we'll do is we're going to stop the recording here, and we're going to just talk to the questions that have come in through the chat box and through the Q&A function, and we'll be able to discuss with you very specific circumstances. So thanks very much for joining us.